Good afternoon, everyone. Yes, the audio is on. We'd like to give people a chance to arrive and get in before we get started. We have some slides that we always share at the beginning of various resources that providers have. I'm Andy Reese, the Director of the Department on Disability Services. Welcome. Happy Friday to everyone. We have a rather full agenda today, so I want to jump right in. As people are aware, we continue to share our COVID data online. I don't have a slide to share today. What I can share is that we now have had 900, we are reporting online 911 people who have tested positive for COVID. And that is an increase of 1 since October 1st. So that's wonderful. We're still seeing that pretty well under control this winter, which is really nice to hear. I do want, for people who do go online and monitor the reports that we post, I want to give people a heads up that the report that we post at the end of December is going to show about a 15% increase. And that's going to have an asterisk on it. And that's because we did a very thorough audit this month. And what we found was there was this brief window in January of 2022. There were some problems with the reporting. There were about 15 positive results that did not get reported. So we're going to add that to the total now, and we'll reflect them back to January 2022. The positive thing about this is, for one, none of them included people that were hospitalized. If they had been, they would have also been reported in another system, and we would have noticed all of this in January 2022. The other positive thing is that reporting is part of a very comprehensive system of support, prevention, monitoring of COVID. And so that one piece broke down, but all of the other pieces were in place. We have really strong supports from nurses within our provider community, ongoing training for them, for the direct support staff who work with people, making sure that we're ensuring people's health and safety on an ongoing basis. And so we did have that one little blip where there was a problem. Those numbers will be corrected and it will reflect. If you go back and look at the data, what you'll see is we had reflected at the time a rather steep drop in December of 2021. People may recall we had a big boost in COVID cases because early December they were really low and then it suddenly spiked. We showed it coming back down rapidly. In fact, it came down a little slowly, but then all spring it remained down. So that's sort of the COVID update for now. We have 4 things on the agenda today. We'll see if we get to all of them. First up, we're going to hear a report from the Bizzell Group from Richard Payton. The Bizzell Group conducted the waiver rate study as one of our ARPA initiatives, and Mr. Payton will walk through the information from that study. Next, Catherine Reinhardt Mello and some folks from our Supporting Families Community of Practice will provide a presentation of it's a spotlight on local resources for caregivers in DC. Just want to mention, I'm sorry we weren't here last month. Last month was Caregiver Awareness Month. So making sure that people are aware of resources that are out there for caregivers in the district. After that, Angela Turner from DDS will provide an overview of the National Core Indicators. And if we have time at the end, I will provide an overview of our comprehensive statewide needs assessment, which is a triennial, every 3-year assessment that's done for the Rehabilitation Services Administration. So now I would like to turn it over to Mr. Payton.
Thank you. Thank you. Waiting for the slides. Okay, thank you again. So this morning, I'll be going over the IDD rate study and development report that we conducted over these past several months. Next slide. So the overarching goals of this was to independently analyze and assess DC's current IDD waiver rate structure. We wanted to determine and update service costs as appropriate, gain an understanding, see if the fee schedule rates paid to the IDD waiver providers are reasonable and appropriate, make rate recommendations, and assess the budget impact of those recommendations. And of course, the overarching goal is to improve overall outcomes for residents with intellectual and developmental disabilities. I'm going to get into the service details. You can go to the next slide. So we looked at the 2024 IDD waiver rate spreadsheet to make sure that we were including all of the services that are rendered by the IDD providers. These slides show the full range of the services that we included in our rate study and for which we created rates. You can go to the next slide. This is just showing, again, the full set of services. Next slide. And next slide. I want to give some background on the rate modeling method. So at a high level, these are the tasks that we went through to come up with the rates and assess the budget impact. We went through to define the categories of service. We analyzed current policies, guidelines, and cost structure. We took a look at cost reports, claims, and provider data. We looked at the rate setting methodologies that other states use, as well as looked at the rates for other states. We received provider stakeholder feedback as we were going through this. We conducted a beneficiary survey to get the beneficiary's perspective on the services rendered. We conducted the provider survey to collect the cost information that providers were incurring during the rendering of the services. We then determined a set of preliminary rates by looking at the provider survey data, BLS data, and looking at the rates from other states. We then created a proposed set of rates, and then we looked at the budget impact of those rates. So we looked at the cost reports. We reviewed 25 unaudited IDD waiver cost reports. We saw that there was a 53% participation rate of the 43 active providers. We also saw that the data was not at an aggregate level, and we were not able to determine costs per service. We also looked at claims data. There was issue with low volume of services, as well as cases where only a small number of providers reported claims. There was no component breakdown of those costs, and we determined that the more accurate cost assessment would come from providers. We sought out stakeholder feedback as well. We had a set of providers in the provider stakeholder group that we engaged with, and they emphasized the critical need for capturing accurate data, particularly concerning vacancies, nursing shortages, and administrative percentages. Providers expressed eagerness to share perspectives, highlighting the gaps in the cost report. And they also identified a need to collect additional cost data not currently collected within the DC rate setting. Next slide. As I mentioned, we conducted a beneficiary survey. We randomly selected 400 of the 1,905 program participants. We conducted the survey telephonically between March 6th and April 12th, 2024. Overall, we found that the beneficiaries were satisfied with the services that they received, giving at least a 3 out of 4 rating for those services. The beneficiary survey did reveal some issues that some of the beneficiaries had. Some of them reported barriers to service accessibility, including limited availability, transportation costs, and staffing challenges. Some of them listed a need to have more educational programs and outreach gatherings for people with disabilities. Historical utilization patterns showed high usage of services such as residential habilitation, personal care, in-home supports, and day habilitation. Some of the bennies identified service gaps, particularly in employment readiness and small group services. But after analyzing the results from the beneficiary survey, we determined that there wasn't really any impact on the rates. We did hand a report of the results of the Benny survey to DDS for additional follow-up. This graph shows the average satisfaction scores for services. So again, all of these services did receive at least a 3 out of 4 rating. The top ones were parenting supports, family training, assistive technology, and wellness. This chart shows usage of the services. The question on the survey was, have you ever used a particular service? So this is sort of a historical usage of it with those beneficiaries that are participating in the program. At the top were dental services, in-home support, day habilitation, and supported living with transportation. For the provider survey, our rationale was to use it to collect additional data for rate setting determinations and provide a way for service providers to give their additional feedback and insights on the IDD service environment. We captured 4 categories of information. We captured basic provider information, such as the name, address, provider ID, et cetera. We captured information for daily rate services, such as residential habilitation and supported living, and the associated details, such as caregiver basic wages, PTO and benefits, productivity, and hourly rates. We also collected information on hourly services, such as physical therapy, and we delineated that by employees and contractors. And then we also collected expense information across program support, administration, and transportation. In addition to that basic cost information, we collected residential home characteristics data, such as average absence days by the beneficiaries, provider staffing patterns and staff hours spent on direct care versus administrative work, annual training hours and new staff training hours, full-time, part-time employee percentage and employee turnover, benefits offered to providers, by providers to employees. And we also provided space for providers just to give general comments. We conducted the survey in 2 phases. The first was a pilot survey. We held discussions with the provider stakeholder group just to understand the gaps and the needed enhancements to the provider survey template to make sure that we were capturing appropriate cost information. We conducted the pilot survey over 3 weeks with the provider group. And then we held a retrospective at the end of that just to see what went well, what didn't, what other additional information did we need to collect, and any tweaks to the provider survey template. We then conducted the final provider survey. It was issued to 222 providers. Of those, 25 responded to the survey. It's a little less than what we would have ideally wanted, but there were 25 that responded. We conducted the survey over 4 weeks, and during that time, we held weekly and ad hoc office hours just to answer any questions that providers may have had. We also conducted one-on-one sessions to help providers upon request. Some stats from the survey. So again, there were 25 that submitted the final survey. There are 285 unique service and modifier combinations from the 2024 IED waiver spreadsheet. We received reports on 58 of those in the surveys. Of those combinations, there were three or more providers that provided information on those combinations. There were cases where there were 2 providers submitting data for those services, and then 24 cases where there was 1 provider submitting data for those combinations of services. Of the 27 broad categories of services listed in the DC fee schedule, there were 6 for which we did not receive any information, and those are listed below. Some of the highlights of the IDD provider workforce, we saw from the survey that providers reported a median turnover of 24% for all direct care providers. Nationally, DSP's rate was 31.7% in 2022, and registered nurses was 18.7%. According to the provider survey, though, the median vacancy is about 1 in 20 positions per month. Median time for onboarding, training of staff is about 49 hours. And the median overtime across services was 8%, with the highest being for companion and supported living services. There were some issues with the data that we collected from the providers on the provider survey templates. One of those issues was missing data. There was missing service parameters and expense data. Productivity data was either filled out partially or missing completely. There was no data for remote services. As far as data mismatch and incongruence, most of this had to do with units being mixed up. For example, person hours instead of person days indicated for daily rate services and vice versa. Mismatch of care units and residential supported living services. Services that required transportation were missing those associated expenses and vice versa. There was out of range data. And for some of the hourly services, providers specified the DC billing rates instead of the actual wage rate paid to the caregiver. Next slide. Another issue was a limited number of submissions. So data was received for only 58, as I mentioned, of the 285 possible service and modifier combinations. And there were 6 service categories for which no provider submitted any data. We also had issues with invalid data. Administrative expenses for some providers were higher than their total direct care expenses. These expenses varied from 6.66% to 104.47%, with a median value of 25.48. Program support expenses was a little bit better, varied from 0.64% to 36.54%. Transportation expenses varied from 0.61% to about 17%. And in some cases, based on acuity, number of beds and locations for day services, the patient days data was inaccurate. Next slide. So taking all of this, I'm going to go into the steps that we use for rate determination. So we compared rate data from 4 sources to formulate the recommended rates. We used the provider survey data when we could. We looked at other states, we used BLS data, and we looked at the current DC rates. So we looked at other states and how their rate setting methodologies went. We reviewed 5 states: Maryland, Virginia, Rhode Island, California, and Illinois. We, for the rate setting, we found that all of the states use BLS data, and 4 out of 5 surveyed their providers for additional details. All of the states did collect information about direct support wages, employment-related expenditures, facility costs, benefits, program support, general expenses, admin expenses, and transportation. For rate comparisons, there were 5 states that we used for rate comparisons. That was Virginia, Maryland, Rhode Island, Delaware, and Massachusetts. We saw among the neighboring states with similar IDD waivers, we found out that there were a set core values that were similar to DC, but there were some services with differences in definitions and billable unit intervals. One other consideration was the administration expense and having to put a cap on that. So again, because of the wide variety of administration expenses that were being reported, we used median values to normalize the data. And that median value was ending up to be 25.48% for administration expenses. But DC's policy warrants that the admin expense can only be a maximum of 20% for some of the services. So since we couldn't use the individual service admin costs due to the wide variation in cost percentage, we just capped the administration costs at 20%, and we applied that to all the services across the board. So next, we looked at the individual providers and calculated the rates on an individual provider basis. So we looked at all of these service direct care costs of the services that they provided. We brought in the indirect care cost percentages that included program support, admin, transportation, totaled that up, and then divided that by the number of units for that particular service, whether it was total hours, total patient days, or total patient hours. We then calculated the service level, calculated the rates at the service level. So we took all of those individual rates, and then we used a median approach to create the rates for each service across all providers. So we calculated the median direct care base wage rate, calculated the productivity amount, calculated the PTO and benefits amount, calculated the total cost for that, and then factored in administration costs, program support costs, transportation costs, and calculated the final rate. As far as using the BLS data to calculate the rates, so we adapted from rate setting processes found in other states that we reviewed, which considered to be the least biased estimate. The BLS salaries were based on the closest occupation approximation for the roles and duties. In cases where duties significantly differ from the BLS description, a composite rate was used based on other states' definitions that were similar to responsibilities of care in DC. The BLS rate was selected based on a profession that would likely render an IDD waiver rate service. For example, the rate for fitness training was based on the hourly salary of a fitness instructor. For the equation for the BLS estimate, we took the BLS wage rate, added in benefits and PTO at 21%, but then added in the productivity, admin, program support, and transportation based on the percentages that we calculated from the provider surveys. And that was because that data is not available publicly. Going to go through some of the rate scenarios. Next slide. So depending on the data that was available, factors considered for rate determination included how similar alternate rates were to existing IDD waiver rates, competitiveness with nearby states, provider survey rate validity, and rate comparability to BLS estimates for service. So this table shows the distribution of the rate sources that we use to guide the rate formation, the formation of the proposed rates, rather. We had 3 cases where we selected rates based on the provider survey rate, 33 cases where we based the rates on BLS data, 184 cases where we left the rate the same at the DC current rate, and 2 cases where we used the median of other states' rates. We also made some adjustments for group and remote services based on the base service rate. So this refers to rate adjustments applied to remote, group, and other variations to the basic services. Also, even though we only use the rates from 2 states for setting the rates, but we did use the state rates as a benchmark against which we compared other rate sources. So I'm going to go through some examples of selecting these sources for the rates. This first one is selecting the rate based on the provider survey. This example is supported living with transportation. So we show the current reimbursement along with the components of that reimbursement. Then down where it says recommended reimbursement, we explain, we show the rates from the different data sources. In this particular case, there weren't any rates available from the states or BLS data, but we have the provider survey rate at $9.32, and that's the one that we decided to go with. Next slide. We show the component breakdown of that rate, which ends up being the $9.32. And we provide the recommendation reason, which was that the $9.32 was recommended because it was within the range of the existing DC rate of $8.69, and it was a reasonable rate. This example shows, this example shows the BLS example for hourly respite. Again, we show the current reimbursement and the component breakdown. Then the chart at the bottom shows the rates from the different data sources. So this one showed the rates from the states as well as BLS data. There was no survey data for this particular rate. Next slide. So again, we show the component breakdown of the BLS 50 rate, and then the recommendation reason, which was it was selected over the DC rate of 703 because the provider survey rate was not available, and the BLS 50 estimated rate is in better alignment with rates from other states. The last example is an example of basing the rate on the current DC rate. So in this case, it was rehabilitation in-person services. Again, showing the current reimbursement and the cost components. Then the chart shows the data from the various sources, the rates from various sources. And our recommendation reason was to stick with the 709 because it was within range of the average of the other states' rates, which was $6.97. Next slide. So in summary, out of the 285 rates that we reviewed, 184 remained the same, 69 increased, and 32 decreased. So this chart and table, this shows the budget impact of the proposed rate versus the DC July 2024 rate. The year-to-year impact of the proposed rates on the projected DC rate is in the range of about 3% each year. So the impact of the proposed rate on each service category in most cases was a 0 to 16% increase. However, in some cases, the percentage change was higher, and this was due to our recommendations in some cases to use BLS rates or other states' rates. As an example, for supported employment job training and supports, the rate was $4.02 per unit. However, the BLS rate was $4.92 per unit. So to be competitive, we chose the BLS rate because other states' rates were higher. And some of the beneficiaries also indicated that supported employment services needed improvement. At the service level, the most increased rates were for supported employment, small group supported employment, and employment readiness. So in conclusion, as a summary, again, we did experience several challenges with the provider survey data, but we were able to use other sources, BLS and other states, in order to formulate our proposed reimbursement rates to enable equitable and sustainable cost recovery for each IDD waiver service. Using our approach, we adjusted 36% of the rates, and the remaining rates did not need to be adjusted because we found them to be in the range of other states and BLS estimates. Once we finalized the rates, we ran a simulation to determine the budget impact for the next 4 years. And our analysis showed that the budget impact of the proposed rates stays within 3.3% of the DC projected budget each year. Now open for questions.
Okay, there have been a number of questions that have been posted, but it does appear to me that Gary Kelly
Yes.
Has been responding to most of those questions. So I am going to go ahead though and read each of the questions. I'll read the response that's been provided in the chat, and then if there's anything in addition that you'd like to add, please do so. So
okay.
The first question, I'm trying to scroll up and find that I have it written down here. Was the rate study open to select providers only? And the response provided here was surveys were sent to all providers, but the response rate was somewhat limited. I'm sorry, his response was, that was my response. His response was, however, not all providers responded. I thought it was a lower response rate that we would have liked to have seen.
Right.
Will the beneficiary survey results be shared? I think the whole rate study will be shared on our website. So those survey results are in the full document of the rate study, correct?
Yes, the beneficiary survey was a separate report, but it's available to be shared if you all choose to do so.
Will this presentation today be sent out to everyone? All of our presentations are posted on our website by the Wednesday after our community forum. In comparing rates from other states, did you factor in differences in state minimum wages, the DC minimum / living wage, and the DSP wage statute? Yes, BLS gave estimates on what profession-specific rates. Then all that also takes into account minimum wage and competitiveness with other sectors in the jurisdiction. Can we have all rate recommendations from this survey for all procedure codes? I think that's included in the study, isn't it?
Yes, we provided a full list of all of the services and the rates that we chose, as well as the logic behind choosing those particular rates.
So the question about the BLS wage also, the BLS rate, the follow-up question is here, do you mean the federal minimum wage or state minimum wage? And does it take into account the DSP Rate Act, which requires payment of direct support staff at 17.6% above the DC living wage?
That, Gary, if you can unmute.
I mean, there's very few professions or services that are rendered by a lay person where the minimum wage would have effect. And in those situations, we looked at nearby states to figure out what would be the most appropriate definition based on sort of the roles and responsibility of like a DSP, and we derived a reasonable rate based on what we saw from those 4 sources. And you know, it's above the required minimum rate for what DC is requiring. So yes, that factored into the rates we proposed when in those circumstances that was applicable.
Thank you. One of the big issues is the adequacy of the nursing rate. Did you include what would be, this says what would be an appropriate number. Did the rate study make a recommendation regarding wages in the rates for nurses?
For nurses in particular, for their rate. No, I don't, Gary. I think that we didn't recommend specifically that rate, but it was just the overall rate. Gary, you can chime in.
Yeah, we have a full list in the appendix of rates that were adjusted. Some nursing services I think were, but we had to be careful because the rates, DC also asked us to apply those rates across programs, so like home health, and we are still collecting the data in that. So in some instances, we deferred making a judgment on that rate until we had additional information come in from that program that constitutes the bulk of that service.
With the use of data from 3 providers, small no for significant, small no for significant statistical analysis, how relevant will your results enhance adequate planning generally for providers?
These rates, we went through, our job was, well, not our job. Our goal was to look to make sure that the rates that are there would be enough for providers to render the services appropriately. And so that was the main objective that we used as we were setting each rate, looking at cost data, the cost of providing the services, comparing it also with other states, looking at BLS data, just to make sure that we could come up with a rate that seemed reasonable to provide that particular service.
So there are recommendations for increasing some rates, leaving some alone. I don't see in this list, and decreasing others was what I heard when you did your presentation, but I don't see that in the question. Is there a nursing brick, for instance, in determining the rate for some services? Yes, because I remember you looked at BLS data and other data to come up with what the nursing wage would be in constructing the rate, if I'm not mistaken.
Right.
And maybe we should have sent the study out in advance so people could have had even more, although then we would have had the whole hour and a half with you. Let me see. I may be at the end of the questions. I believe I'm at the end of the questions, but if someone had a question that they think I have not responded to, please let me know.
Hey, Andy, it's Ian. Can I ask that question a little bit clearer?
Yeah.
Okay, so the question that you had just mentioned, what I was wondering is if Bazell had come up with, is there just like a summary chart list by service line of the ones that they're identifying as up, down, and even? That's what I'm
Yes.
looking for in the list.
Oh, I'm sorry. Yes, that we will post. That is available. They gave us a list of all the services with their recommendation about where each of the rates, with their recommendation regarding each of those rates.
Okay,
Correct?
great. That's what I was looking for. That's what I'm talking about, a list, like just kind of like to be able to, rather than kind of pull through everything, like which ones are the ones that are gonna, would possibly be effective if additional funding were provided. Thanks.
I think that's the end of the questions.
Okay.
So thank you very much. And as I said, we will be posting materials on our website next week and be available then to answer follow-up questions for folks. Thanks a lot. That was a lot of information. So I think it'll help when people have the report to digest themselves, and they may have more follow-ups then.
Okay. Thank you. Thank you.
So next up, Catherine Reinhardt Mello from DDS, and she's going to be joined. They're providing a spotlight on local resources for caregivers in DC. And this is a presentation from the Supporting Families Community of Practice. And I want to recognize that she will be joined by Azeb Aderi, Rhonda White, Shauna Holmes, Wendy Jones, Tanisha Lawrence, and Bernitrus Parker. So I will turn it over to you, Catherine, and I apologize if I messed up anyone's name, please correct.
All right. Hello, everybody. Thanks for giving us a few minutes of your time today to share some of the work and resources from the Supporting Families Community of Practice. We recognize that the role of caregivers, oh goodness, what's happening with my slides? That the role of caregivers in the lives of people with intellectual and developmental disabilities is often the primary work. Goodness. Apologies for my slides. I don't know what's going on there. Sorry about that. But that usually families are the primary source of support for people with intellectual and developmental disabilities. They're often the primary caregiver. So that's about 75% of folks are supported by families primarily as service systems. So we think that it is very important to be able to support those individuals in their roles as those primary caregivers. And that's really what the Supporting Families Community of Practice is thinking about. And we're working together as both a DC chapter and as a national chapter for Community of Practice. So we're able to share our own resources, some of the things we're working on in DC, along with best practices here and across the country with our national partners. All right. Charlisa, do you mind sharing? Because there's something funky. There's going very wrong with my my presentation.
Yes. 1 second.
Yeah, sorry about that, folks. But we have many partners in our community of practice that have various roles. Some of them are primarily focused on supporting caregivers, and others have specific programs to support caregivers across the district and sometimes regionally. So you'll hear about some of those resources today from our partners. And first up, we have Azeb with the Ethiopian and Eritrean Special Needs Community to talk a bit about what they offer.
Good afternoon. My name is Azeb Adari. I'm one of the founders and the president of the Ethiopian Eritrean Special Needs Community, which is a non-profit organization to support the and empower individuals with disability and their families. We mainly support the Ethiopian and Eritrean community that is growing in number in this area, but we also support other African community members such as Uganda, Kenya, Nigeria, and recently Ghanaians too. We provide culturally sensitive programs that focus on personal growth, family support, and building strong community connections to meet the unique needs of each family. The caregiver support, we have three main components to support the parents. The first one is Parent Cafe, very successful. It's been over 4 years now. Think of this as your safe space. It's where you can connect with other parents who understand your journey, share experiences and strategies, and find emotional support and practical resources. And the next one is the caregiver skill training. It's designed by World Health Organization. We offer workshops to help parents improve communication with their children, develop effective behavioral management techniques, and understand child development strategies. And we also cover transition planning training. This is crucial for parents preparing for their child's future. It helps them navigate the educational transitions and understand their legal rights, the children's legal rights, and the parents, how they can involve in that, how they can be part of that, and how they can develop personalized transition plan with the school and explore post-secondary and vocational opportunities. The other program we have is educational support, which is a special education and ABA, applied behavioral analysis. Q&A sessions. ABA, for those who don't know, it's behavior management technique. It has a strategy. We provide clear guidance. Parents come in, it's virtually, it's free. They log in to ask questions. If they have any question about special education or child's behavior, we do twice a month, one for special education, one for ABA. The other one is a very successful program, which is a youth program. We did peer mentoring program supported by DC Council. We support young individuals building self-advocacy skills, develop job readiness, promoting independence, providing targeted guidance. This program is mainly led by BCBAs, the ABA people, but peers are very huge part of it, and the individuals with disability are really loving this, making friendships with typical peers, and that it opened up with that. And we also have, while most parents raising their children, they never focus on their culture, teaching their culture to their kids. So through cultural arts program, it's a unique program that helps neurodivergent individuals connect with their cultural heritage, express their creativity, strengthen their family bonds. Additional support we have is a monthly in-person meeting, expert-led training sessions on various topics. While parents are trained, children are cared for. And this is a huge opportunity for parents to come and connect and also learn new strategies to help their children navigating the special needs services or navigating healthcare, navigating the government services. And we do all of that throughout all these programs. And if you would like to connect with us, please email us at eesncdmv@gmail.com, or you can find us at www.eesnc.org. Thank you so much.
All right, next up we have Tamisha Lawrence from Advocates for Justice and Education.
Hi, good afternoon, everyone. My name is Tamisha Lawrence. I am the Parent Support Specialist and Training Specialist with Advocates for Justice and Education. We are an independent organization, not a part of DC government or any school system. We are the family-to-family health information center and the Parent Training and Information Center for Washington, DC. Every state has one. However, we are designated to DC. We serve families who have early age children, birth to age 3, school age children, ages 4 to 12, and transition age youth between 13 and 26. We offer a free parent training, and we speak about the special education process, IEPs, 504s, school discipline, working with your child's school and medical team, helping to empower effective advocacy within your home, both you and your student, preparing your young person for life after high school. We also offer family service. We also offer trainings to family service professionals as well. As direct services for families, we offer advice and counsel, one-to-one coaching, information and resources. And we also have opportunities for parent ambassadors, Parent Leadership Academy, Parents Building Bridges program. And we also offer direct services that are supported by YouTube. We have YouTube library of trainings where if you want to get support and understand some of the trainings that we offer, and we also do them virtually and in person. And we help assist with filing systematic state complaints. AJE's goal is to empower, educate, and advocate. And if you ever want to reach us, you can either walk into our office at 1200 G Street Northwest, Suite 650, or give us a call at 202-678-8060. And you can complete an intake with our intake specialist, Nadia. The next up is Ms. Rhonda White with Quality Trust.
Good afternoon, everyone. My name is Rhonda White, and I am the Family and Community Engagement Liaison at Quality Trust for Individuals with Disabilities. Within my position at Quality Trust, I am the program coordinator for the Family Ties of DC. However, my cherished role is being a parent of 4 children, in which my youngest beautiful daughter with special needs initiated my passion to advocate for people with disabilities. The Family Ties of DC is a parent matching program for parents or care supporters of children and adults with disabilities in the District of Columbia. The Family Ties of DC is an alliance member of the National Organization for Parent-to-Parent USA. Family Ties of DC adheres to the PTP USA standards of peer connection by the program coordinator, myself, who is a parent of a loved one with a disability, is creating matches between a support parent, which is a trained volunteer with similar lived experiences, with a referred parent who is requesting connection regarding a need for themselves or their loved one with a disability. Family Ties of DC reminds parents in the district that they are not alone in our evolving parenting journey by arranging meaningful connections for the referred parent to receive information, resources, and emotional support by the support parent. Well, I believe the slides are not up, but on the slide in which indicates all of the information about how to request a parent match request. The process starts with the submission of the parent match request form that can be found on the Quality Trust website. Also, I'll include it in the chat. The program coordinator, myself, will review, contact the referred parent to gain further information and determine the support parent appropriate for the parent match. We also have the opportunity for parents to be trained to become support parents. Those parents that feel like they can give to another parent and have experienced things in their journey. And the support application can also be, support parent application can be found on the Quality Trust website. And of course, we also welcome the participation of partners, agencies, and organizations to support the work of the program and share the program with parents and care supporters. We are thankful for the support of the DC Developmental Disabilities Council, who supports the program. I will share my information in the chat, as well as all the links for the information. Thank you, and I appreciate this time to share our program. I believe the next presenter is Craig Lean, who is my fellow co-chair for the Family Support Council.
I don't think Craig is on yet. Do you want to keep going, Rhonda?
Okay, well, I will fill in. The Family Support Council is a council of parents, family members, self-advocates who are interested in providing and coming together as a council to provide recommendations to the Department on Disability Services and their sister agencies here in the district. These recommendations that we provide to those agencies will ensure that we are offering things that are person-centered and family-centered recommendations. Craig Lean and myself are co-chairs, and we are continuing to work with the council to make sure that we are reaching out to the community of parents. It is important that we hear for the community so that we can develop those recommendations that will benefit the lives of our loved ones. Our next meeting, I believe, is January 9th at 1 p.m. Right now, we are focusing on recommendations concerning Medicaid, the police interaction with our community, as well as some of the internal workings for Family Support Council. So please share this time, the meeting time and date with your families and community at large. Thank you. And
next up, we have Wendy from the USED to talk a bit about some of their resources and supports.
Good afternoon, everyone. I'm Wendy Jones, and I want to talk with you today about two programs. So first, the Georgetown Parenting Support Program. It's a DC Health funded home visiting program in its 6th year now, supporting pregnant and parenting persons with disabilities and their children from 0 to kindergarten. The Parenting Support Program provides support to parents around child development and growth, strengthening parenting skills, providing real-time supports at appointments, and some case management services. So really, we are the only program in DC that is solely the only home visiting program in DC that solely is dedicated to providing services and supports to parents with intellectual and developmental disabilities. If you have interest in this or have parents that you'd like to refer, 202-394-6091 or parenting support program at georgetown.edu is the easiest way to reach us. Also, the second program, the Transition Implementation Partnership, or TIPS program, was a 4-year project focusing on parents with intellectual and developmental disabilities and supporting the transition of their children through the life course, or as they grow and develop and move through different transitions, school, from early childhood across through high school and beyond, and in their transitions and navigating different services. So this program is over now, but the most important piece is that there were many programs, many different things or different tools developed. What I want to shout out about this program is that there were tools developed to support caregivers, and 6 actually really videos that were developed that feature parents with intellectual and developmental disabilities. So 6 videos featuring parents and focused on healthcare, on early intervention system, on school system, and child welfare. And for other folks like policymakers and other interested individuals, there's training modules too, and there's policy and practice guides to help you shape, adapt, or change policies and practices to, again, support parents with intellectual and developmental disabilities. So I believe next up is Bernie.
Hello,
I'm sorry,
everyone.
I just wanna, Bernie, I'm sorry, before you get started, I just want to jump in. Point out there are 2 questions in the chat I want to make sure we respond to, which are, I believe, related to Rhonda's presentation. How do you become a member of the Family Support Council? And please share the meeting date and time.
Thank you, Andy, and thank you, Brenda. Yes, you can join the Family Support Council. There is an application that can be found on the DDS website, which I will place in the chat, as well as the meeting time and date information so that you can participate in the meeting. Thank you so much, Brenda, for the question.
And just so everyone is clear, that's an open meeting. So whether you're on the council or not, I believe everyone is welcome to come to the meetings, correct?
That's correct. It's a public meeting. As I was sharing that, it's open to the community at large. You could be someone that doesn't have a loved one with a disability, but you want to share in the work of helping us to support those who do. So welcome to all, please join us.
And I'm sorry, one more question. That's a virtual meeting, right?
Yes,
Or
it
is it in person?
It is a virtual meeting, and we will, the link will have to be provided at a later date when we send out the actual meeting invitation, that Catherine can get that link to the community at large. But yes, it is a virtual meeting. Thank you.
Thank you.
I'll put my email address in the chat, and if you want information about any of this to add to our family's mailing list, then just shoot me an email and tell me to add you.
And you all will get the copies of these presentations for all of the groups that have spoken. All of our information is in the presentation materials, and feel free to reach out to all of us. Thank you.
Great. Thanks a lot, Rhonda.
Hello,
Hello.
everyone. My name is Patricia Parker. I'm the DDS Medicaid Waiver Program Specialist. I will provide information of DDS, IDD, and IFS waivers, family training, parenting supports, respite, and participant-directed services. Family training provides coaching, consultation, and other professional support services to families or unpaid primary caregivers of persons enrolled in the waiver. The training focuses on how to improve the caregiver support of the person or gain a better understanding of the services outlined in the person's ISP and plan of care. Parenting supports assist people who are or will be parents in developing appropriate parenting skills. This service is available to expectant parents, parents with physical custody, visitation rights, or parents who are pursuing reunification with their child. Parents training is individualized and focuses on the health and welfare and developmental needs of their child, as well as building necessary parenting skills. Respite services are the provision of short-term temporary relief to those who are caring for family members enrolled in the waiver to enable them to participate in scheduled or unscheduled time away from the person. Respite services will ensure that persons will continue to receive services and have access to community activities as described in their ISP and plan of care. The My Life, My Way program, which we refer to as participant-directed services, is available to participants in the IFS waiver. PDS is a great service option for persons looking for more flexibility and autonomy over their services. The PDS delivery option is available for in-home supports, individualized day supports one-to-one, companion one-to-one services, and respite daily out of the home, and individual directed goods and services. Services in the IFS waiver are capped at $75,000 per ISP year. If you have questions regarding the My Life, My Way PDS services, please contact Shauna Holmes at shauna.holmes@dc.gov. Information can also be put in the chat and is available in the presentation. If you are interested in exploring any of the waiver services, please contact your assigned service coordinator to discuss available service options or service coordination program managers. If you have any questions specific to the IDD or IFS waiver, you can contact myself, Bernice Parker, or the waiver supervisory specialist, Pamela Harmon. There are also 2 slides at the end of
Okay, given the time, I think next up, Bernitris was going to say we have Shauna Holmes. Am I right or no?
Bernie was doing my part.
No, I'm
Yeah.
presenting for Shauna. She's sick, guys. She has laryngitis, so I'm presenting on her behalf.
So are we next up with Tanisha Lawrence?
So she's already spoken. I think
Sorry.
that's it for us. So I'm going to try to drop the slides in the chat here shortly, and then we can also add them to the website. So if you heard something that may be helpful for your family, or if you support people with IDD who are involved with their families and may benefit from some of these supports, please share them far and wide. And then let us know if you have any questions or want to get more involved in any of the things that we discussed today. Sorry again for the technical issues. Thank you.
Thank you. Technical issues aside, those were really interesting presentations and lots of really helpful information. And as all of our presenters said, all of the slides that were prepared will be available on our website by Wednesday next week. So next up, we have Angela Turner with Department on Disability Services, and Angela is going to talk to us about the National Core Indicators data.
I was muted, but I was about to say good morning, but hello, good afternoon, everybody. I'm Angela Turner, Project Manager for the Quality Assurance and Performance Management Administration. And just as Andy said in the beginning, I'm going to give an overview of the results from the 22-23 survey and a snapshot of some of the results that we see in that we saw in the data, just to kind of also give people an idea of if you were kind of on the fence of wanting to take the survey and because you really didn't know what it was going to say or where it would go, this is a great opportunity to see how the state is reflected in comparison to other states, and just how far your voice went in just submitting those surveys either by mail or participating in the interview. So it'll be a snapshot, not all of them. There are 3 reports, and I'll also have the website link. I'll put it in the chat, but it's also at the end of this slide where you can go and read these surveys in detail for yourself, which I encourage everybody to do. Thank you. Sorry. Yeah. So it's a national program that uses standard surveys to gather and collect data from people with intellectual disabilities. Each participating state gets an opportunity to customize by adding questions that fit to the language that they used. It was launched in '97 to be able to give direct feedback from people receiving long-term services, tracks quality measures and outcomes of developmental disability services for people with IDD and their families over time, and monitors the stability and quality of the direct support professional workforce. Next. So 48 states, along with the District of Columbia and 21 regional developmental disability centers in California, participate in the survey. States can use the data to track changes in performance and compare outcomes across states, monitoring national trends. Agency managers can use the reports to develop new initiatives, new policies, establish benchmarks, and track progress toward quality improvement goals. Some states actually use this tool for their quality measure direct to their agency. Next slide. So these are the 3 surveys that take place during the for the National Core Indicators: an in-person survey that's done face-to-face, and it's for people who receive at least 1 paid service, and it looks at person-centered planning and outcomes. The other one is the adult family survey that's mailed. You can mail it in or do direct online entry. And it's for families who have an adult family member living in their home that also receives services, but also at least 1 paid services in addition to case management and supports. It allows families to be able to show how supports are impacting the lives of the families that's receiving services. Now, the State of the Workforce survey is for the provider community. It's online. It is for those who provide residential employment, day services, and it's another way of showing stability and quality of the direct support professional workforce and giving the providers the opportunity to speak on it from their perspective. Next. So they measure and compare national data for the in-person and adult family surveys. in categories of person-centered planning, outcomes and satisfaction in such domains listed below: self-determination, service coordination and access, relationships and community inclusion, rights, choice and decision-making, employment status and goals, health, welfare, and safety. Next. States can measure and compare national data for the State of the Workforce Survey in responses related to turnover rate, DSP separation, tenure, and you'll be able to see how how DC pairs up to other states as far as size of agency and number of DSPs. Next. So starting with the in-person survey, you can see the national stats next to the DC stats. 25,424 surveys were completed face-to-face nationally. Of those, 354 surveys completed face-to-face for DC. 61% of our data collected were from people the people receiving services were valid. 99% of that data collected was from the proxies that were valid. And I'll talk about proxies in a minute. But you can see how we pair up nationally, which shows that we are just a little under the national average as far as having valid data. All right, so these are the domains that the in-person survey looked at: individual outcomes, system performance, workforce, health and welfare and rights. So these are the questions that came out of from these domains. So areas DC ranked above the national average. Portion of people who live with others who report they can stay home. So we paired against the other states. We fell above. I mean, we rated above. Proportion of people who report that they do not feel lonely often. So we were above, and in the report you can see where we are, but there were several states and everybody had everybody was pretty much equal to the national, but with size and everything, it was still ranked as far as who is at what portion of the rating you come in, excuse me. And a proportion of people who report their service plans include things that are important to them. Next. So areas we ranked below the national average were for a proportion of people who report satisfaction with the level of participation in community inclusion activities, percentage of people who report that they had help to make their plan, and a proportion of people who report adequate transportation. So slightly under, but just slightly under in comparison to the national average. Next. So looking at the adult family services survey, also looking at the nationwide and district, 9 states, including the district, submitted a valid sample of adult family surveys. And I'll talk in a second. I'll talk in a little bit about how it goes out. And the total sample size nationwide was 4,988. For the district, we mailed out 639 surveys for adult family surveys. Of those, 166 were usable. 46%, it was almost half and half, but 46% did paper submissions and 54 did direct entry submissions. So the domains looked at in the adult family survey: information and planning, choice and decision-making, access and support delivery, workforce, which was new as of 21-22. Now, these are the surveys that go directly to the families, and they're the ones that fill out this survey and speak to the supports from their perspective, how their family members receiving it, the access to, the quality. Also even asking what do they want to know more of, and you can look to the states to see how much information people are looking for to get help on. But for DC, you can see we rated above. Oh, next slide. About to go into it. So DC ranked above the national average for families who felt like that they got enough information to take part in planning for their families, services for their family. How accessible did their service coordinator listen to their family, listen to their choices and opinions? And do you feel like the plan includes all services and supports your family member needs? So again, DC was rated above the national average for these areas. Where we ranked below the national average, you have to the way the questions I think with the family survey go is it is more of a do you have it and how do you like it? Do you need it and was it offered to you? So it's almost the objective to and their feeling how they perceive the quality of it. So where we rank below were for if you use respite services in the last 12 months, were you satisfied? If you filed a complaint, were you satisfied with how it was handled? And if you were in a crisis, were services provided when needed? So again, below the national average, however, slightly below the national average. Next. So looking at the state of the workforce survey, this is the one that is online for the provider community to have a voice also in this process. So nationally, 26 states, including us, participated. Of that, 93 of the 104 surveys for our provider community were participated in the survey. 465 DSPs reported on not patrol, payroll, sorry, typo, as of 12/31/23. Next. The domains for the state of the workforce that were in the questions: demographics, collected, tenure, wages, benefits, recruitment and retention, and frontline supervisors. You can, using this data, you can really see where, like I said, where DC stands in comparison to other states, which we'll get a quick snapshot to. Next. So just a little graph, spread of agency size as of December 31, 2023. So you can see where we are with the red arrow there in comparison to other states. Now, also what you'll find directly in the report, you'll get to see the exact numbers so that you can get a good estimate on size, because of course a larger state would probably have, would have larger numbers here, but all that's taken into account into how the data was processed. Next. So I looked at turnover, tenure, separation, some of the highlights from that, from those results. Data showed a 2.2 increase in turnover ratio from 22. DC reports that 4,448 DSPs on tenure as of December 31. And the way the report is, it's anybody, I believe it's just at 6 months, just because just at 6 months, but we can, I think I'll answer that in the next one. 1,169 separations as of the 31st of December, 74.6% of active full-time DSPs, 25.4% of active part-time DSPs. So a lot of good information that can be used, directly for your agency. Next. For some reason it's a little cut off. I apologize. So looking at tenure, turnover, tenure, and separation, the results also showed the percentage of total separations seen in 23, because I meant to mention the state of the workforce survey is for the year, as opposed to it's done every year. The other one is not done. We did this one last year, but the other one wasn't. So I apologize for that. So yes, here where we are weighted against the national average. DC reported a vacancy rate of 7.3% for full-time DSPs and 12.8% for part-time DSPs. Next. Just some highlights from the wages area results. DC was identified as one of the states of having an increase in one of the largest above the national average for median hourly wage across all service types. And you'll see where we're falling in the graph right there, where we are with the red arrow pointing us out, where how we kind of pair up salary wise of the participating states. So we are now currently in the new national core indicator cycle. It started in July and it runs all the way to 25. We will be participating in all 3 surveys, in-person surveys, adult family surveys, and the state of the workforce survey. And the survey results for the last survey we participated in for 23-24 will be ready for in 2025. That way, when we get those, it'll be our opportunity to really pair it up against. We didn't have anything to measure from last year, the last cycle, because we didn't do 2 of the 3 surveys. But going into next year, when we receive those results, we'll be able to pair it up against this year. We'll be able to really look at DC from these results to the next year to see how well we've done from the perspective of people receiving services. So like I said, I'll put these in the chat, and this will be in the PowerPoint you receive. These are resources direct for you, the direct page, the link to the survey and the survey reports and FAQs. And as your NCI IDD contact for DDS, there's my email and my number if you have any questions. We look forward to looking at these results for next year. I encourage everybody to participate. It's a wonderful way to get your voice out from a state level. It's not just DDS that looks at this data. It is state councils who make the laws and make larger decisions for the city. Researchers to be able to start looking at different things as caregivers and for caregivers and people who receive services. And yes, so you should be receiving those in mail. Families should start to receive those in mail soon. And providers will soon get their invitation to participate. And also the people who decided at their ISP that they wanted to be a part of the survey should be getting contacted soon as well. So thank you.
Thank you very much, Angela. I just want to mention, I may have missed it, but I want to make sure I mention that DC Quality Trust and PROMESA are the 2 agencies that conduct these surveys for us. And we have the data because they've done such a great job of conducting the surveys and collecting the information. So we do learn the information that we need. I also want to give a shout out. The return rate from our providers is excellent and gives us really good data regarding our workforce here in the district. As with all the other presentations, the slide deck will be online by the middle of next week. And then all the information we have regarding the results of the NCI data will be posted on our website. I don't see any questions right now for Angela. I do want to mention, people may notice we're at 1:28. There was one more topic. Certainly not getting there today. However, so the last thing that we had on our agenda today, and with our planning committee next month, we'll talk about when we'll revisit this, is the comprehensive statewide needs assessment. This assessment that's required to be done by RSA every 3 years is what's supposed to inform our vocational rehabilitation state plan. And it was due in 2023. It was not actually completed until 2024. And so our state plan was done without it being completed. Because of that, we have our updated data, and we will be doing an amendment to our state plan next summer. So we're going to be working with our state rehabilitation council to look at the results from the comprehensive statewide needs assessment and look at any changes that we need to make to our plan based on the needs. And so actually the timing of doing this maybe in January or February would be pretty good, because we will be working with the SRC starting in January to look at an amended state plan for that will be submitted to the Department of Education by next July. I do see Charlisa has put a link in the chat to the comprehensive statewide needs assessment that is posted online. It is, I will tell you, a very comprehensive quite long assessment. So in this instance, you will get the opportunity to review all of this before we do the presentation. It's just under 200 pages. And then we will do this presentation either January or February. So we look forward to seeing you all again next month. Thanks to all the presenters today. This was a whole lot of really good information. Have a great weekend, everyone.